Newborn exam, head to toe. This video will demonstrate the key aspects of the newborn physical exam. We will focus on identifying normal versus abnormal physical findings. We will also highlight findings that may suggest a congenital anomaly or a genetic condition. Before beginning the exam, enter the room calmly. Congratulate the family on the birth of their baby. Introduce yourself and explain your role. Ask the family for permission to perform the newborn exam. Wait for their agreement before proceeding. Carefully place the infant on her back. Gently unswaddle her or remove the blanket to allow full visualization. Begin with general observation. Note whether the baby is asleep or awake. Assess whether the baby feels warm or cool to the touch. Observe the baby's breathing pattern. Look for any signs of respiratory distress, such as rapid breathing, grunting, or retractions. If the baby shows signs of distress or illness, stop the physical exam immediately. Notify the supervising resident or attending physician. If the baby appears well but is crying, attempt to console her. Gently place your hand on the baby's head. Offer a pacifier if the parents allow. Ensure the baby is calm and comfortable before continuing the exam. Proceed with the physical exam in a systematic head-to-toe approach. The simplest way to organize the exam is as follows: head, face, neck, chest, abdomen, genitalia, extremities, back, and neurologic exam. Head. Begin by examining the head. Gently place one hand behind the posterior portion of the occiput to support the infant's head. Measure the head circumference in centimeters. Wrap the measuring tape just above the eyebrows. Continue the tape around the head to the most prominent part of the occiput. Bring the tape back to the starting point to complete the circle. Determine head size by plotting the head circumference on a newborn growth chart. The head circumference should fall approximately in the same percentile as the infant's length and weight. Observe the shape of the skull. The newborn skull is made up of several bony plates. These plates meet along flexible cranial sutures. Identify the fontanelles. The anterior fontanelle is the larger diamond-shaped opening on the top of the head. There is also a smaller posterior fontanelle located at the back of the head. Identify the cranial sutures. The coronal sutures run across the top of the head. The lambdoid sutures are located at the back of the skull. The sagittal suture runs from front to back along the midline. The metopic suture runs down the center of the forehead. Understand the purpose of this skull design. The flexible sutures and fontanelles allow the skull to be malleable. This flexibility helps the baby's head pass through the birth canal during delivery. As a result, temporary skull deformation may be present. This is called molding. Molding is common and typically resolves on its own. Continue examining the infant's head by inspecting the skull for bruising and swelling. Look for cephalohematoma. Cephalohematoma is a firm swelling that does not cross suture lines. It is caused by bleeding beneath the periosteum. Cephalohematoma is more common in births assisted by forceps or vacuum. These infants have an increased risk of jaundice due to the breakdown of hemoglobin from the bruise. Next, assess for caput succedaneum. Caput succedaneum is a soft swelling that crosses suture lines. It is caused by fluid accumulation above the periosteum. This swelling typically resolves within a few days after birth. Also evaluate for subgaleal hematoma. Subgaleal hematoma presents as extensive swelling that crosses suture lines. It occurs due to rupture of emissary veins. This condition can lead to serious complications. Significant blood loss may occur within this potential space and requires urgent attention. Face. After gathering general information, begin examination of the face. Assess each facial feature individually. Start by examining the ears. To assess ear placement, imagine a straight line drawn from the outer corner of the eye. The upper portion of the ear should meet this line. If the ear sits below this line, it may be low set. Next, imagine a second line drawn perpendicular to the first. Assess whether the ear aligns normally along this axis. If the ear tilts backward, it may be posteriorly rotated. A typical ear positioning is not dangerous by itself. However, it may prompt consideration of an underlying genetic condition. Now, assess ear formation. Check whether the ear has a complete rim of skin surrounding it, known as the helix. Examine the skin fold inside the helix, called the crus. The crus is usually smooth and well-formed. Finally, inspect the skin in front of the tragus. Look for ear pits or skin tags. These are variations in ear formation. Many ear variations are normal. However, minor variants may be associated with genetic conditions. They may also be associated with hearing loss or kidney anomalies. Chest and cardiovascular exam. Begin by listening to the baby's heart. A normal newborn heart rate is between 120 and 160 beats per minute. At faster heart rates, distinguishing systole and diastole can be challenging. Many newborns have a continuous machine-like murmur caused by a patent ductus arteriosus, or PDA. This murmur is common and benign. In full-term infants, it typically resolves within the first few days of life. Other heart murmurs should be evaluated carefully. Murmurs that persist or do not improve over several days require further investigation. Evaluation may include pre- and postductal oxygen saturation measurements. 4 extremity blood pressures or an electrocardiogram may also be obtained. Respiratory exam. Next, assess the infant's breathing. It is normal for newborns to have short pauses in breathing. They may also breathe at a slightly irregular rate. This pattern is known as periodic breathing. Auscultate the lungs at the apices. Listen along the sides and the back of the chest. Normal breath sounds include clear air movement. There should be no wheezes or crackles. A normal respiratory rate for a newborn is 30 to 60 breaths per minute. Abdomen. Move on to the abdominal exam. Begin with inspection. The abdomen may appear mildly distended. The skin around the umbilical cord should appear clean and dry. Many infants have an outpouching of skin at the umbilicus called an umbilical hernia. Gently press the hernia back toward the abdomen to assess if it is reducible. A hernia that feels firm or cannot be reduced may be incarcerated and requires evaluation. To assess the liver, place one hand on the lower rib cage. Gently press on the right side of the abdomen. The liver edge should not be palpable or should lie very close to the ribs. Palpate all quadrants of the abdomen. Carefully assess for masses. Although rare, some infants may have intra-abdominal tumors. Examples include neuroblastoma or Wilms tumor. Groin and femoral pulses. Unfasten the infant's diaper. Assess the femoral pulses by placing your fingers along the crease between the thigh and diaper area. A steady pulse should be felt on both sides. If a pulse is absent or significantly weaker on one side, consider aortic coarctation. This can be further evaluated with pre- and postductal oxygen saturation measurements. 4 extremity blood pressures may also be obtained. At this time, check for an inguinal hernia. Genitalia. Now evaluate the genitalia. In infants with female genitalia, the labia and clitoris may appear enlarged. This is due to exposure to maternal hormones. Some newborns may have a small amount of vaginal discharge or bleeding. This finding is normal. Vaginal skin tags may be present at the posterior fourchette. These are common and benign. In infants with male genitalia, palpate to ensure both testicles are descended. A swollen scrotum may indicate a hydrocele, or fluid collection around the testes. Hydroceles typically resolve on their own. Examine the penis carefully. Ensure the foreskin fully covers the glands. Check that the urethral opening is in the correct position. A hooded foreskin may suggest hypospadias. In hypospadias, the urethral opening is abnormally positioned and not at the tip of the penis. Anus, hips, and back. For all infants, assess the patency of the anus. Use one hand to gently spread the gluteal cleft. Next, assess the hips for developmental dysplasia of the hip. Hip dysplasia refers to congenital misalignment or instability of the hip joint. It is more common in females. It is also more common with a family history of hip dysplasia or breech presentation. Inspect the lower back. Look for a sacral dimple. Determine whether the base of the dimple can be clearly visualized. If the base cannot be seen, consider underlying spinal abnormalities such as tethered cord or spina bifida occulta. Other concerning findings include a patch of hair over the lower back. An asymmetrical gluteal cleft may also suggest a spinal cord abnormality. Neurologic examination. Begin the neurologic assessment with general observation. Note whether the infant is awake or asleep. Assess whether she appears calm or irritable. Determine whether she is consolable or inconsolable. Muscle tone. To assess muscle tone, gently pull the infant toward you. Observe whether her body feels stiff and hypertonic. Also note if she feels floppy or hypotonic. Bring the infant to a sitting position. Observe whether her head lifts with her body. Significant head lag may indicate decreased muscle tone. Motor function. Assess motor function primarily through observation. Note whether the infant moves all extremities equally. Check that facial movements are symmetric. Sensory response. Assess sensory function by observing the infant's response to touch. Normal infants will respond appropriately to gentle stimulation. Primitive reflexes. Evaluate the infant's primitive reflexes. Note whether the reflexes are symmetric. Asymmetry may suggest a neurologic or orthopedic condition. Begin with the Moro reflex. Support the infant and lift her a few centimeters above the bassinet. Gently allow her head to fall back into your supporting hand. The hands should open. The upper extremities should extend and then retract. Next, assess the palmar grasp reflex. Place your fingertip into the infant's palm. The infant should wrap her fingers around your finger. Then assess the rooting reflex. Gently stroke the infant's cheek. The infant should turn her head and open her mouth in anticipation of feeding. Hip examination. Assess the hips one at a time using 2 maneuvers. Begin with the Barlow maneuver. Adduct the hip by bringing the thigh toward the midline. Apply gentle posterior pressure to the knee. This tests for hip instability. Next, perform the Ortolani maneuver. Flex the infant's knees to 90 degrees. Gently abduct the hips by moving the thighs outward. A palpable or audible clunk may indicate hip dislocation. All neonates with risk factors should receive a hip ultrasound. This is recommended at 4 to 6 weeks of life. This applies even if the physical exam is normal. Extremities. Inspect the extremities. Confirm the presence of 10 fingers and 10 toes. Some infants have a small skin nubbin. This may represent post-axial polydactyly, type B. Assess the length of the digits. Short fingers are referred to as brachydactyly. Long, slender fingers are called arachnodactyly. Examine the palms. A single horizontal crease is called a single transverse palmar crease. This finding can be normal. It may also be associated with conditions such as Down syndrome. Missing or extra digits should prompt further evaluation. Back and skin. Gently turn the infant onto her side or stomach. Inspect the back. Look for blue-gray macules. These are common and typically fade over time. Also note other normal newborn rashes. Erythema toxicum may appear as pustules on an erythematous base. This rash commonly appears within the first 24 to 48 hours of life. After completing the exam, change the diaper if needed. Re-swaddle the infant for comfort. Thank the family for allowing you to examine their newborn. Ask if they have any questions.